And we see your laser pointer too.
Hey, thank you to NorCal for hosting this webinar. I'm excited to have the opportunity to talk to individuals that I don't get to talk to here every day. So thank you for all of you that joined. I am, as Arash and Kyle mentioned, going to talk about transcutaneous spinal stim, or as you'll hear me say more commonly, TSS, from the clinician's perspective. So my name is Emma Buckley. I'm a physical therapist at Neiroworks, which is an outpatient PT and OT clinic in Utah. We specialize in the treatment of spinal cord injury rehabilitation. And for the last several years, a large part of my clinical work has focused on transcutaneous spinal stimulation in individuals with spinal cord injury. I use TSS regularly with my patients and have conducted some small case studies looking at its effects, primarily using devices that have been available in clinics for many years, as Kyle mentioned. But I also participated as an interventionist in the Inuvo clinical trial, and now more recently, for the last year, have had the opportunity to trial and play with the ARC-EX. So my TSS experience ranges across multiple devices, and I've used it on a wide array of patients, injury levels, severity of injury, and levels of function. I am very passionate about TSS, as a lot of my patients know, and I find it a very promising intervention to enhance the outcomes for individuals with spinal cord injury, which, as we all know, is very needed. I've shared my experiences at conferences and provided some in-services to help others try to implement TSS responsibly. So my goal today is simply to just explain what TSS can and cannot do, what we know and what we're still learning about its application, and then how to interpret the most visible study in this space, which is that Uplift trial for the ARC-EX device. We'll dive in a little bit more in depth to the results and what those results and outcomes mean. Again, we want to just help people with spinal cord injury make informed decisions, as this is becoming a very hot topic in clinical practice and in research. So there is a lot that I could say about TSS and how we got to where we are today, but in the interest of time, I'm going to shorten that part of it. But if you're interested, this podcast from Unite to Fight Paralysis does an excellent job breaking down the history, the key players, how we got to where we are today. It's part of a multi-episode series that dives deeper into each of the devices, where the research started from, where it is now, and where we're going next. I often recommend this podcast series to patients who want a deeper understanding of what we're doing and why. So if you want to explore more of the scientific mechanisms and research in more detail, this is a really good place to start. TSS is built on decades of epidural spinal stimulation research that was the first kind of breakthrough in spinal stimulation, and showed that the spinal circuits below an injury are capable of creating movement, but often are dormant because they aren't receiving enough signal to produce those muscle contractions. However, epidural stimulation requires surgical implantation, while TSS uses a non-invasive approach to target similar pathways. The goal of TSS is to increase excitability, essentially to turn up the volume of signals that are trying to be sent to muscles, but are not getting through loud enough on their own. So across many years of research, there are documented benefits of TSS, primarily including improved motor activation, or strength, spasticity reduction, and sensory gains. As Kyle mentioned, there also are quite a few indirect effects: improved blood pressure regulation, sleep, quality of life. Some people experience reduction in pain. So those are some of the things that you'll see across the research. Until December of 2024, there were no devices with FDA approval specifically for TSS. So this is where Kyle mentioned they've kind of opened up a new category of devices and are the first one that has been specifically designed for this application. While Onward achieved the first FDA approval, other companies, as Kyle mentioned, like Inuvo, are still pursuing approval. And I think it's important to note, too, that there are devices in clinics today that are capable of delivering similar parameters through off-label use. So the big piece that sparked this webinar is that Onward recently received FDA approval for home use for these devices. Last I knew, they are not yet able to be covered by insurance, so it is just an out-of-pocket purchase. And this is what we want to kind of explore today and talk about what we know and don't know and how I would recommend and advise individuals with spinal cord injury approach this intervention. So I wanted to create a visual. As you can see here, this wave represents an individual's volitional effort to try to create a movement. So say you're trying to raise your arm, squeeze your hand, kick your leg, etc. And when you have a spinal cord injury, those signals are not able to get through the injury site as loud as we need them to hit this kind of target that would then produce a muscle contraction. So TSS is not creating a movement or it's not creating an artificial signal. It's really just turning up the volume so that those patients' individual efforts are then able to hopefully create a muscle contraction. So this is what makes TSS different from other forms of stimulation that you may have experienced, like an FES bike. Instead of forcing a contraction, TSS aims to support the individual's own effort to activate their muscles below the level of injury. Before we dive too deep, I want to just briefly review how spinal cord injuries are classified using what's known as the ASIA exam. This exam is typically performed shortly after an injury and assesses motor and sensory function at each spinal level. It's typically performed by a doctor in the hospital. They look at 5 key muscles in each arm and leg that are tested for strength, and then sensation is assessed for both your ability to tell light touch and also a sharp pinprick through every single level of the spinal cord. So the results are then used to assign an ASIA classification you'll often hear, and that can evolve over time. So sometimes your ASIA score that you're given in the hospital does not necessarily reflect where you are months or years down the road. But what those classifications are, in a simplified version for the sake of time, gives a severity rating for the injury. So from ASIA A to ASIA E, with A being the most severe and E considered normal function. ASIA B injuries typically preserve sensation, but not motor function below their level of injuries, while ASIA C and D injuries preserve motor activation below the level of injury. The difference comes in the amount of strength and the number of muscles that you have access to, and how far below your level of injury they are. Generally speaking, ASIA C and D injuries have greater potential for change because those intact motor signals below the level of injury can hopefully be trained and strengthened. So to create a visual, ASIA A and B injuries may be more likely to be wheelchair bound or need significant bracing to stabilize them to stand or walk. And ASIA C and D can vary significantly from someone who is wheelchair bound but with a little activation below their level of injury, like a higher level quadriplegic that still has hand function, to somebody that walks without an assistive device. So I want to highlight that because as we look at this and we interpret the data and what we're seeing, there is a broad spectrum of severity of spinal cord injury, and I think these are important to keep in mind. So what is TSS and what is it not? TSS is a safe, non-invasive form of electrical stimulation applied directly over the spine. It's designed to influence the spinal circuits or pathways below the level of injury to improve sensation, motor control, or some of those autonomic functions below the level of injury. However, as Kyle mentioned, TSS does not work alone. The stimulation is providing an environment that allows for improved training intensity, repetition, exercise tolerance, and potentially access to new muscles that can then be trained. However, if you simply put on TSS, it will not produce the same functional outcomes if you're not pairing that with training effort, ideally in a skilled setting, but obviously with home use, that changes things. TSS does not cause regeneration of damaged neurons or pathways in an injured spinal cord, and it is not a cure for spinal cord injury. Importantly, it also does not guarantee improved function for all individuals with spinal cord injury, which is what we're going to further explore. Well, we have come a long way in our understanding of TSS, particularly as we're at the point where we're getting FDA approval for these devices. There is still a lot that we don't know, and I've talked to researchers in the TSS field that still say we're looking at the tip of the iceberg, and there's a lot that we have to learn as the application of this intervention becomes more widespread. So it has been well documented in years of studies that TSS has the potential to create meaningful changes in individuals with spinal cord injury. However, these effects are greatest in the incomplete, particularly that Asia C and D population. That's not to say that there's not any benefit for Asia A or Asia B. There are studies that have shown that they can benefit, or that those individuals shouldn't still trial TSS and may have a very good response, but the likelihood of positive response or the capacity for change is often reduced with more severe injuries. More recently, the Uplift FDA clinical trial demonstrated safety and feasibility of the ARC-EX for use with arm and hand function, specifically in chronic incomplete spinal cord injuries. So right now, that is where the FDA approval is limited to. They are in the process of doing lower extremity studies, and that is certainly the goal. But right now, the FDA approval does limit it to upper extremity function in chronic incomplete injuries. But there is still a lot that we don't know. There are no published studies comparing these newly approved TSS-specific devices to clinically available devices that can deliver similar stimulation. And there was an analysis done of the data from the ARC-EX clinical trial that provided a generalized approach to how we approach programming these parameters and finding the right ranges for each individual. But it's really difficult in spinal cord injury studies to create direct comparisons because every injury is so different. And unfortunately, this also makes it hard for us to learn if one approach is better or more efficient than another. So this is a huge area where it really matters to work with a clinician that understands this stimulation, the parameters, and how we can try to figure out how to maximize that for each individual. We also don't have a lot of long-term data on the functional gains of TSS. There are no large-scale long-term studies to assess if or how well the improvements gained from TSS are maintained outside of clinical trials and consistent skilled therapy. And we don't have studies that show carryover with consistent stimulation or what frequency is needed to maintain that. So do you need to wear the device every day? Do you need to have stim active to keep the benefits? Or can you get to a point where you just use the device intermittently and have sustained benefits? Those are things we just don't know yet. And then, as Kyle alluded to, when we go from research to more widespread clinical practice, the response is not always the same. Clinical implementation of the ARC-EX is still in the very early phases, and as the number of clinicians using this device with a wide variety of training, background, and familiarity with TSS begins to expand, we don't know what we'll continue to see with that response rate as it compares to the clinical trial. So I want to dive into this study that kind of changed everything in the spinal cord injury world, particularly with TSS. So this was the clinical trial that allowed Onward to get FDA approval. It's known as the Uplift trial. They used a study design where each individual acted as their own control. So they participated in 2 months of skilled therapy alone, focused on upper extremity function to establish a true baseline, and then followed that by 2 months of TSS combined with task-specific training with either PT or OT with a sole focus on upper extremity function. This study was for chronic incomplete cervical spinal cord injuries with a study population that heavily weighted towards the Asia C and D range, with 85% of participants falling into those two categories. Asia A injuries were excluded from this study, so there's a lot that we still need to learn about the application in that classification. And there also was a minimum level of function that was required to participate in this study. I'll get to that in a minute and take a closer look at what that looks like, but you had to have a certain level of strength or a certain degree of functional movement in your arms and hands in order to participate in this study. So if you followed the news of the FDA approval of the ARC-EX, you've probably seen these statistics. These responder rates are certainly impressive, especially given the chronicity of patients and how far out some of them were from injury. I'll dive deeper into what being a responder really means in a minute, but they did find that Asia C and D participants made greater improvements across the board, supporting the fact that the more incomplete the injury is, the greater capacity there is for change. They were able to show that when compared to the 2 months of rehabilitation alone, there were more significant improvements made in many of the outcomes when the therapy was combined with TSS, which is important because it helps support the fact that the improvements from that point forward were related to the application of TSS and supports the effectiveness of this intervention. So I want to dig a little deeper into the responder criteria to help you all understand what this actually means. 72 and 90% of people responding sounds very impressive, but I don't want you to think that 72 to 90% of people necessarily had a life-changing improvement in strength or function. So I want to quickly define what it is that they were looking for here, which is what we call a minimum clinically important difference. So in research, we often look at what is a statistically significant change, but in this world, that is valuable, but it doesn't always capture what a change actually means in function in daily life. So each of these outcomes have been tested and validated and have a certain threshold that has been found to indicate that the level of improvement made would be expected to make a significant difference in that individual's daily life or function. So to define a responder, they utilized 4 strength outcomes that you can see here and 2 functional outcomes. If a participant met that target improvement in 1 strength and 1 functional outcome, they were considered the primary responders, so that accounts for that 72%. If they met that target change in either 1 strength or 1 functional outcome, those were the secondary responders that accounted for 90% of the participants. It does not mean that they improved in all areas, and these improvements can look very different depending on the outcome, and we don't have the in-depth information of the long-term carryover or retention of those benefits. So I want to take a minute to walk you through these to help you understand the results. We'll stay on this slide for a couple of minutes, so bear with me here. The upper extremity motor score comes from that Asia test that we looked at, and the 5 key muscles in each arm, think shoulder, elbow, wrist, and hand, are tested and graded on a 0 to 5 scale for strength. This leaves a maximum score of 50 between both arms, and the MCID for this test is at least a 2-point improvement. So in one individual, that may mean that a muscle that wasn't firing at all is now able to produce a visible contraction or a twitch, but may not be a functional contraction. And it could mean that a muscle that was weak and limiting the performance of a functional task now reaches the strength level to improve that. The grasp strength is similar, but it tests 10 muscles in each arm, so gives a little bit more detailed picture of strength. The scoring is similar, but on this test, they want to see a 4-point increase overall to indicate a significant change. I do think it's important to note that in order to participate in this study, individuals were required to have either a minimum score of 30 on this test or a 10 on the other grasp measure, indicating that there was a baseline threshold of strength or function that was required. And this is really important when we think of translating the findings of this study to the real world, where individuals with less than a 30 are looking at these findings and considering the purchase of a unit or making a significant investment to access a clinic where they could trial this device. And I think it's important to understand what function was already there for those individuals participating in this study. Grasp and pinch force are pretty straightforward. They just use a device that measures the force that you can produce, either pinching your thumb to your pointer finger or grasping an object in your hand. If we now look at the functional outcomes, they used another portion of the grasp test that measures the efficiency or the coordination of arm and hand tasks, like pouring a bottle of water, opening a lid, inserting a key into a lock, or picking up small objects. The score for this test takes into account the time that it takes to perform the task, as well as the number of errors during the test. This is the other grasp component that was taken into account when selecting participants. So on this test, you were required to have a minimum score of 10 if you didn't already meet that strength threshold with the 30 on the test above. So this means that most of the participants in this study were able to perform these tasks to some degree at baseline or had a reasonable amount of strength preserved in their arms and hands. And then the final functional outcome is what we call the QT, that similarly looks at how well you can actually use your arms and hands for real-world tasks like reaching, lifting, bringing your hand to your mouth, as well as some tests that overlap with the grasp, like pinching and manipulating objects in your hands. This test includes 17 items, so the total possible score is quite high at 128, and they wanted to see a 4-point improvement here. So, what does all of this mean? My goal is really to help you understand what changes they may have seen or didn't see. And I think it's really easy to read these findings as, wow, 90% of people improved, and you envision a functional improvement that really changes what daily life looks like. But more often than not, they likely improved their performance of tasks they could already do, and by the end of the study could maybe do them more efficiently, more quickly, or with less errors. And I want to be clear that I know for individuals with spinal cord injury, this is very meaningful. I'm not trying to take away from the significance that an improvement in efficiency of task performance can mean in your daily life. I just want everyone to understand that the improvements with TSS aren't always and are almost more often that you don't gain a new functional movement that you didn't have before. It may just mean that you get better and more efficient at doing what you can already do. So to look at what this means for the responder rates, and this is just kind of creating the low end of the picture, but to understand that the threshold for meeting the responder rate may not be as high as you envisioned that it was. So an increase in grip strength by 1.5 pounds may let you fall into that 90%, but what does that really mean in daily life? And similarly, the 72% that were primary responders could have been individuals that made a 2-point improvement in the efficiency of tasks they could already perform, and then increased strength marginally in 2 upper extremity muscles. Again, I'm not trying to minimize the findings, and these findings certainly existed on a spectrum, and I'm sure there were some individuals that improved in all of the outcomes, but that's just what we don't know. So I wanted to create a visual of what these responders could look like and what we still don't know. To visualize this, I really think of responders to TSS on a spectrum. This is just my clinical model, not necessarily directly taken from a study, but is supported by research and experience. So we can typically group responders to TSS on a spectrum, but in 4 main categories. On the left in blue, we have non-responders. This is individuals that for whatever reason don't respond functionally to stimulation. It often captures those more dense or severe injuries in the Asia A and B categories. However, as Kyle mentioned, with the indirect effects, they may still feel better, which is a common report, or may have improved blood pressure regulation, which can certainly be significant. They just aren't getting an improvement in functional movement. And then in the second section in yellow, we have what I'm calling the stim-on responders, meaning that while the stim is on, they feel better, they're more efficient with hand movements, their balance may be more stable. However, when stim turns off, that benefit goes away and they don't get much, if any, carryover. The third category is where we start to see more carryover and changes in function. They may not gain a significant new movement, but they're able to do things more efficiently or with less errors when stimulation is turned off. So this is where people would have started to be classified as a responder in the Uplift trial. The final category is those lucky individuals where TSS really opens up a new door for them, either getting a new movement that they didn't otherwise have, or making a significant difference in the efficiency of tasks that allow a whole new level of training. And that's where you can really start to see if you are able to now perform a new task and you continue performing it, that's where you start to see those movements retained long term. And what I wanted to show with this visual is that the vast majority of people are not falling into that fourth category. Again, I'm not saying that doesn't mean there can't be significantly meaningful changes in your daily life. And without a doubt, for those individuals, this stimulation can be life-changing. All I want to show is that the response to TSS does exist on a spectrum, and you need to decide what degree of change or response is worth it to you. I can't sit here and say for any individual what threshold makes personally seeking out one of these devices worth it. I just want to shine a light on what expectations may be most realistic. One thing that I think is really helpful that the Uplift trial did is they went back and analyzed all of their data at the end of the study and tried to identify factors that made individuals more likely to be a positive responder. This doesn't mean you need to meet all of these criteria, and it doesn't predict what outcomes improved or to what degree, but it does create a picture of which individuals may be more likely to reach that positive functional response. And I think this may be useful as individuals assess the cost benefit of a home unit or pursuing the cost to seek out one of these devices. Unfortunately, these tests are best performed by a trained therapist, but I'll break down what they are assessing. Some of these we've seen before, so I'll try not to bore you with the same information. These first three all come from that Asia exam that we saw in the beginning. So the upper extremity motor score reflects your voluntary strength in those 5 key muscles on each side. So having a score of about 50% means that you have noticeable but incomplete strength in your arms, but enough movement for training and stimulation to potentially build on. The total sensory score measures how much light touch and pinprick sensation you have across your whole body from the neck down on both sides. So again, they're looking for about a 50% threshold. The upper extremity sensory score comes from that same information, just narrows it down to looking at the areas that are key for using arms and hands. And here they saw that actually about a 60% of normal sensation puts you in a more likely category to respond well. Again, the pinch and grasp force are pretty straightforward, but this does suggest that having a reasonable amount of hand and fine motor function can be really important. 22 pounds of grasp strength in a chronic quadriplegic is not an insignificant level of function. And then the QT, again, looks at how well you can actually use your arms and hands for 17 different real-world tasks. The threshold for this was a little bit lower at 30%. And then finally, the grasp sensibility score, this is a different area of the grasp than the ones we've seen, looks at specifically how well your hands can feel and tell the difference between different sensations, which helps with gripping and handling objects. So across these tests, people who benefited most from stimulation typically had anywhere from 30 to 60% of maximum strength sensation or arm and hand function. That's of what would be considered fully normal. So from my personal experience with TSS, the biggest thing that I cannot stress enough is how individualized the programming is. I think this is one of the biggest areas that we need to improve our understanding of to make sure that we're actually maximizing the potential of these devices. There are often general recommendations for programming that are made that often emphasize providing the greatest level of stimulation tolerable. But in my experience, there is actually such thing as too much stimulation. So if you don't have somebody that's willing to really spend time trialing different parameters, you may be missing the actual potential benefit. As of today, as I said earlier, there are no studies that compare the Onward to clinically available devices. It undoubtedly has a portable component and can now be purchased for home use, but there are clinically available devices that I've seen produce the same, and in some individuals, even better results. And then, as myself and Kyle have both touched on, we are in the early adoption and early rollout phase of this device, and we as a clinical community still have a lot to learn about how best to maximize this device. So, particularly as you consider either the costs of traveling to a clinic to use this device or purchasing one for home use, these are some of the things that I recommend considering. Nobody can decide what improvements are worth the cost to you. For some, that may mean getting a little bit more sensation back in your arms and hands. For others, that may be a significant improvement in daily function and the tasks you're able to perform. These responder predictors are not the end-all be-all by any means. Remember, I said that we still have a lot to learn, but for everyone, especially if you fall closer to the Asia A or Asia B categories and don't meet those responder prediction thresholds, I would strongly recommend doing a longer trial in person with this device with a skilled clinician to really determine your best response before you purchase a device. Typically, in clinical trial studies, the benefits can be seen by 1 month of use, if not sooner, at typically a frequency of 2 to 3 times a week. I can't stress this enough. Please try a device in person. Even individuals who appear to meet responder thresholds don't always see meaningful improvements despite extensive parameter trialing. TSS is so highly individualized, it really does require time, experience, and constant reassessment of your response. You really need to work with someone who's willing to spend time trialing parameters, because that can also evolve over time as your system gets used to the level of stimulation. And I know the last one is hard, especially if you're in a more rural setting, but there are clinically available devices that are already widely used in PT settings for other things that are capable of delivering parameters consistent with TSS-specific devices. They aren't available to get for home, but if you have a therapist willing to learn how to set it up and utilize it, TSS can be safely applied with devices we already have and that are more cost-effective for a small rural clinic if they're willing to invest in one. I could go on about this for a long time, and I'll maybe save that for another time, but TSS is more accessible than I think a lot of people think it is. Clinicians just have to learn how to do it. So I think at this point we can open things up to your questions.
Thank you, Emma. Can we actually, is it okay if we jump into the testimonials from Dan and myself?
Oh, yes, absolutely.
And do you want to go just maybe stop screen share?
Yeah.
No? Dan Scrivener, I know you're there. Do you mind coming onto the camera?
Hi there, Arash and everyone else.
Thanks, Dan.
Can you see me okay? All right.
Yeah, we can see you, hear you great. So we are going to do, just going to have Dan share really briefly about his experience. He has quite a bit of experience with various types of TSS, and then I'm going to share a little bit about myself. But Dan, I'll pass it over to you first.
All right, let me get my information here. I got a lot of reference material here because I have had a fair amount of TSS. So just a little backdrop because it ties into what both Kyle and Emma have shared. So I'm 68 years old, and 8 years ago I had a bicycle accident where I sustained a C4, C6 incomplete injury. And my initial assessment was an Asia B, and that improved over time to an Asia D. And I would say probably took over 2 years where I feel like I gained most of my improvements. I have impaired hand function, which is more pronounced in my left hand. And for my lower extremities, I have limited ability to walk using a walker and forearm crutches with limited endurance and in particular impaired balance. And I still use a power wheelchair depending on how far I need to walk. I also have significant nerve pain and spasticity tightness in my hands and more so in my legs. So I went out to Neiroworks kind of independent on my own, independent of NorCal SCI back in July of 2024. So I went out 4 weeks of 7 years out from my injury. And my goal was to try and improve the fine motor function in my fingers and independent finger movement and just try and make things a little bit easier with complex tasks. And then my legs, I was trying to improve my right hip flexor. It was very tight, improve the range of motion, improve my balance, the quality of my gait, and hopefully try to improve how far and fast I could walk. And also I was hoping it would reduce maybe my nerve pain and spasticity. So I actually had 1 hour of OT for my hands and 1 hour of PT for my legs. And we used, as Emma was alluding to, they used a Chattanooga vector unit off-label that provides very similar TSS parameters to the ARC-EX. So we used that. And I'm just going to reemphasize, the key thing was that Emma and Sydney, who was the OT, extremely knowledgeable at experimenting and optimizing with the pad size, placement, settings, and that was really critical. And just continuing to reemphasize, it was paired with really intense activity-based training, especially my lower body. Emma really worked me harder than I had been working before, for sure. So my experience, I would say, probably took at least probably 4 to 5 sessions before maybe I saw a little movement changes or felt like it. And the kind of echoing what both Emma and Kyle said, it felt good while it was on. My fingers relaxed and loosened up. I did see a little improvement in finger dexterity, and I was able to do some of the tasks that they had me do. And this would vary day to day between sessions. So that's another thing that I saw. There was variability. So at the end of 4 weeks, we did some testing. We do the pre and post testing that both Kyle and Emma alluded to. And I did see some improvements, but I really never had any retention or carryover when it was turned off each day or after 4 weeks. So that was kind of my experience with my hands. And then my legs, same thing. It felt good while it was on. It had a little more impact on my lower body. Again, I put in a lot of effort for the whole 4 weeks. I had some improvement in my balance and endurance and confidence. Worked really hard on my right hip flexor, and that's one thing that I was really happy that improved the flexibility and became stronger, and it helped improve my gait a little. Here, the testing helped me as well, or the rehab with TSS helped me. I walked a little farther and a little faster, and I felt like I retained a little bit more of the improvements or carryover for my lower body, especially my hip flexor and my balance, and a little bit for walking. But like I said, depending on how far I walk, I have to use a power wheelchair too, because of shoulder issues. Unfortunately, it didn't reduce my nerve pain or spasticity. So fast forward to this last year, I went back in September for 3 weeks to try the ARC-EX. Unfortunately, I had an accident in May that significantly increased my spasticity and tightness in my hands and legs, and impacted my function quite a bit, as well as some additional nerve pain. So there was a big increase in my finger contraction and use, and also spasticity in my legs. So my goals in September were just to try and regain some of what I had before May. So for this round, we used the ARC-EX, but we also ended up using the Vectra. The ARC was more comfortable because they use, I won't get into all the details, but they use a carrier frequency that allows you to use a little higher current than with the Chattanooga Vectra. So that was a little more comfortable when they would turn up the current. My hands, I actually had less response this time because of the increase in spasticity, especially my left hand. I do think the ARC-EX maybe helped a little bit more than the Chattanooga, but again, very subtle. Same thing as in 2024, it felt good while it was on, but I really didn't have any retention after each session or after 3 weeks. So legs, ARC-EX and the Chattanooga felt pretty similar. It's really hard to assess. It's somewhat subjective. Similar to 2024, I had a little more impact with my legs, where I was able to increase endurance, a little bit of balance improvement. We really worked on that a lot. Hip flexor was okay. Actually made some improvements in walking distance and speed in spite of all the spasticity. And I do feel like I did have a little bit of retentions, but my balance is worse. So for me to wrap up, the pre and post testing does provide some objective data. Remember, it's in a controlled environment. But then there's the practicality of how you translate that to your everyday life, especially the need to keep up a really strong exercise program and try and maintain any improvements. just like after any rehab. So overall, it was an excellent experience. The Neuroworks staff and facility are outstanding. I can't say enough good things about everything they do, and we are so grateful for all the critical rehab they provide to the SCI community and others with neurological conditions. Thanks.
Thank you, Dan. All right, I'm going to make a couple of comments. I want to keep them very, very brief because I want to allow for some time for questions. Just one thing to add, NorCal SCI does provide grants for outpatient therapy and exercise, especially for the newly injured. We define that as less than 2 years. So the Franklin Project is a grant that allows participants to go to Utah, to Neuroworks, where Emma and Kyle are working. And we, as Dan said, we're so incredibly impressed with the facility and the staff there. It's just a state-of-the-art facility. And in addition, if you want local options, the grant programs we offer also can work with SciFit, which has 5 different locations in Northern California. And all of those locations do have the ARC-EX. I don't believe they have other TSS devices, but I might be wrong about that. So if you're in those first 2 years of the injury, then please check that out on our website and apply. I will keep my personal comments really, really brief because we're a little behind. I'll just say I'm a C5-6 injury. I'm technically a C7 Asia B. I have tone and some spasms in my leg. I'm not able to ambulate or stand or walk. I can stand in a walker just using my tone. But kind of by accident, I was independently, not through NorCal. I was at Neuroworks in 2024. They threw on the Vectra, the Chattanooga, the same device Dan was talking about. And I had a super response. I all of a sudden could take steps. I could walk on a treadmill. I could walk on land with like a support, a light gait or a walker or something. So because of that, I actually went and did, same as Dan, a 3-week case study at Neuroworks. I had a really strong response to the Vectra. And I do have full sensation throughout my body, and I can feel the stim quite well. As a result, it felt great. I also had some other things that were doable, which were I was able to get my heart rate much beyond where I normally can. I normally can't get above 100 beats at my heart rate, and I was able to get up into 140, 150. I was able to sweat. It was just almost like having a completely different body. I'm not going to say that I all of a sudden had full function of my legs. I want to make that very, very clear. I couldn't just suddenly control my legs, but when I was in the right position and putting my body in the right positions, I was able to step quite successfully. As a result, when the ARC-EX came out last year, Neuroworks asked me to come back in 2025 to kind of do a side-by-side study to compare the ARC-EX with my experience with the Vectra. So I did just go to Neuroworks in November and did that. My personal experience with the ARC-EX was not as successful. I did not have the same response. I didn't have the same ability to walk and take steps. There was some of that, but it was a lot more of a struggle. And I did enjoy some of the same benefits of like an increased heart rate, but not as much. And I couldn't sweat as much as I could with the Vectra, the older technology. So I'm going to leave it there. There's a lot more to say, but I really, really want to wrap it up and give everyone a chance to ask questions. So this is the chance. I'm going to remove my spotlight. If you have a question, please use the raise your hand function on Zoom and I can unmute you. And please keep your questions brief and, try to keep it to the topic at hand, not a very, very personal question about your condition. That's something that's better discussed offline with a practitioner. So any questions on here? I do see some things in the chat, but I'll get to that in a second if someone wants to raise their hand and ask a question here. All right, we'll jump to the chat. Emma and Kyle, someone said, Could you comment on the outlook for FDA approval extending to AISA participants, either with opening the trial to complete injuries or for home use? So I think they want to know if Asia A, what the status is there. So, yep, I got you. Sorry.
I do not know FDA wise. What I will say is that, at least here, and I think in most clinics, clinicians are pretty comfortable using the device off-label for an Asia A patient. The FDA trial clearly showed safety. We have other research studies that have shown benefit in the Asia A population. So, as Kyle said, they kind of select the population where they expect to see the most change to be able to capture the effect of the device. But I think pretty quickly that gets translated to clinical application in the Asia A population. I don't know how that works with home use and doctor approval, though.
Thanks, Emma. We have another, first a comment, someone with an OT, someone who says they're an OT. Sorry, I don't know who this is. It says SCI day treatment. I've been using TSS with patients and really enjoy using it to augment therapy. Did you guys have any negative effects, skin breakdown, AD, etc.? And then there's a question about the pads. I'll just respond for the first part. I don't know the pads. I'll leave that to you to answer, Emma. I did not have any negative effects, no skin issues. Again, I do have sensation everywhere, so that helps. I could tell if something was feeling off, but the ARC-EX was much more uncomfortable for me. I could not, I wasn't getting a great reaction, and when the stim would get turned up, it just didn't feel great. It kind of locked me up. It got me more spastic in tone. With the Vectra, that was less so. It was the higher you got, the more intolerable it became, but it was really easy to know, okay, this is too much, or this is just right. And it did vary day to day. Some days I was feeling a little weaker. Towards the end of the week, I need a little higher amount. And some days I was able to do that with less stim. So very different results for me personally with the ARC-EX versus the Vectra. And Emma, can you comment on what pads did we use? I don't know if you see the question here, 1.25 inches or 2x2 pads for the spine.
Yeah, if we're doing cervical spine, the onward recommendation with the ARC-EX is the small round pads. I personally don't find that they stick very well or are very well tolerated. So on the cervical spine, I usually use 2x2 squares. But if I'm using it lower down, I'm more often than not using either a 2x3 rectangle or a 3x4 rectangle on the spine, and always 3x4 rectangles for the dispersal pads on the stomach. And I will just touch on skin breakdown and AD are certainly the two biggest things that we're watching for with patients. I personally have not had issues with it. There is research to suggest that TSS can predispose people to being at a higher risk for AD, but I've also seen it do the opposite, where they're in a little bit of mild AD and the TSS brings it down. So I think that gets chalked up to another one of those highly individualized response. It's always something that we're watching, especially when we first start trying TSS with a patient, but it hasn't been something that's been a big issue for us.
Great. And then Dan, if you don't mind, and actually someone just said about bladder control, so I'll just, no changes for me for bowel bladder or anything else with TSS. Dan, do you mind commenting on if you had any negative effects and also bladder control?
I did. It was pretty similar to you that obviously I could feel with the Vectra when we turned it up too high. I'm trying to think. I don't think I had any skin issues where it started to break down a little bit. I think that's one of the potential concerns, is just skin breaking down a little bit if you're doing it day after day.
And what about bladder? Any improvement or changes?
Pardon?
Bladder. Any bladder changes?
Oh, no bladder. You know what's interesting? I'm thinking maybe bowel might have. Again, that's pretty subjective. Maybe a little bit, but it's not bladder.
Okay. Anyone want to raise their hand? Otherwise, I've got another long comment question here in the chat. All right. All right, in the chat, also an OT here. Emma, Kyle, which other clinically available devices have you seen similar or better benefits? I know Vectra was mentioned. She lists a few other units here, Excite, Ridgemere, portable units. Not sure if you mentioned that usually considered beneficial for those who meet even one of them or multiple. Guessing some go together, and the more, the better. Sorry, yeah, I'm trying to make sense of the question. Happy to chat separately. So hopefully you saw that and can answer.
Yeah. The Chattanooga Vectra is the most common device that we use, and the one that we first started using with TSS. We use the Vectra Neo. That device is able to get to that 1,000 microsecond pulse width, which is kind of the biggest target for TSS. People do use the Excite and the RT300 for TSS. You just have to get a splitter that you just have to kind of modify it a little bit. I'm happy to chat with you about what that looks like. Responder predictors, I think, is just so individualized. I personally put TSS on almost every spinal cord injury patient I treat and just see what I see. And then we kind of make a decision as to, is this worth the setup and, you know, some of the limitations of the portability of the device for the benefit that we're getting, or do they not respond significantly, and how it aligns with patient goals. Some patients really want to try doing it regardless of how positive their response is. So hopefully that answers your question. I'm also happy to give you my email and we can chat.
Thanks, Emma. Someone else, Lena, asks, is it worth trying TSS for a complete T7 level injury? These are probably hard questions to answer, but I'll leave it to you.
Personally, I would. If you have a place that you can access it for not an extreme cost, those thoracic level injuries with a more spastic upper motor neuron presentation have the best potential. I can't make any promises, but I always say that it's worth trying.
Okay. Thank you.
I did see there's one question about bladder control improvement. I personally have not had patients. Part of what's hard is I often see patients in that first year from injury. So sometimes patients are getting improvement in bladder control, but I certainly can't specifically tie that to TSS. I do know that there are some people that have reported with more consistent use that they do see some improvements in bladder control, but I think that's an area where they're still trying to gain more better understanding in the research, and I don't think there's widely a significant improvement.
Thanks, Emma. Someone asks, can you share the best response you have received thus far? Is that me or somebody else?
Yeah.
That's with the Vectra. Yeah.
Yes. So RAsh is definitely probably the biggest super responder we've ever seen. So he was able to go from able to stand but not able to initiate a step to, at the end of 3 weeks, walked over ground with a walker without me helping to step or advance his legs, and that was when the stimulation was off.
Yeah. I will say that there wasn't much carryover with that as well. It's not something I could do it when the stim was on, but it's not like I could come home and do it then. And I didn't feel, if I had, just hypothetically, if someone gave me a device for free, I honestly wouldn't feel super comfortable doing much at home with either of the devices, because I would feel much more safe in a clinical setting. The function that I was able to not regain, but to have, was not so predictable that I would want to do that. So just to clarify. Okay, someone says, how much do these systems cost for home use?
I believe the price tag that I've heard for the ArcEX is $30,000.
Yeah, and I think Kyle or Emma, maybe or I don't know all the details, but the one you use in the clinical setting is $40,000, right? And then the one they're releasing for home use is $30,000, but it has a little bit of a limitation. I think that might actually be useful for our audience to know what that limitation is, so that the person who, let's say, has $30,000 sitting around, it is important, because I think there's something about the programming. Can you share a little bit about that, Emma?
Yeah, so the Chattanooga Vectra is actually like less than $5,000. which is where if you can find a PT clinic that has those devices and a therapist that's willing to learn and to figure out how to apply it safely, that is much more cost effective. The ARC-EX is even more expensive than the home use price tag for clinical use. So I saw that there's a question about where you can find it. For the ARC, I know that they have on Onward's website, they have a list of all of the clinics in every state that has the ARC-EX. So that's one place to start. For the other, my kind of off-label use for the clinically available devices, I think is going to be harder to find advertised and going to take a little bit more of contacting clinics and seeing if you can find a therapist that does use it, that has that experience, or if you can find someone that's willing to learn. I'm always happy to help guide people in how to apply that, because I want to see TSS applied much more widely in the spinal cord injury population than it currently is.
And Emma, sorry, just to follow up on that, can you comment on that piece of like what the person who buys the home unit can or cannot do? Because there's an important difference there, right? About needing to get it programmed a certain way or not having the customizability that you all have at the clinic. Can you touch on that?
Yeah, so that really comes from the safety perspective, that the settings that are available on the ARC can certainly put people at risk if they're not programmed correctly. So if you get a doctor prescription for home use, you need to have the device programmed to you in a clinic, and they will set the parameters, and then they give you a range that's usually there are a couple parameters that you can't adjust. The only thing you can change is the intensity, and it will lock you into a window of adjustability. So I think that's something really important to consider. That range can be changed, but it needs to be changed by a clinician. So I think as we start seeing things rolled out to home use, that's another thing that we're going to learn a lot about, is how well, if you only have the same settings that you can access every day, when do we need to have those progressed? How do we progress them? How frequently? Are all questions that I don't think we have the answers to yet.
Emma, can you also clarify, is it only for cervical for hand function, or can they also use it for lower extremity function?
The FDA approval is only for upper extremity function. So the doctor prescription and all of that will be for, you're going to need to have your upper extremities affected by your injury in order to qualify. In clinics with therapists is more often where you're going to see that off-label FDA use for lower extremity.
Yeah, someone in the chat said they got a quote, 29,000 plus tax. So, yeah. Important to think about. Other questions? Use the chat. Otherwise, we will wrap up. All right. Well, I think Dan, Kyle, Emma, anything else before we sign off? Any last words of advice or wisdom you want to share, or anything at all? Please, the floor is yours.
I'm going to throw my email in the chat, so if people do have questions and want to follow up with me, I'm happy to field those. I think for me, I'm a huge proponent of TSS. I think it is certainly the most exciting, biggest step forward that we've had in treatment for spinal cord injury, to open up a new window, a new potential, and augment the therapy that people are already getting. So I hope that came across, that I'm certainly a huge fan of this intervention, and I use it on a daily basis in my practice. I think I just want to make sure that people go into, as we see these headlines that are very exciting, that we know what we're actually expecting, and finding ways to try these devices before stepping into that big purchase, to really understand what it does for you and what it doesn't.
Thank you. Kyle, anything on your end? No. Here. You're unmuted now.
No, that's great. Emma wrapped it up perfectly. I think the big thing is, if you're not able to get immediate access, there's a lot more information coming. It's still very new. if you can be patient, if you can wait, we may have a better idea. You may have a good idea of what that cost benefit looks like for you down the road. Like the question regarding bladder function. Bladder function was something that was tracked in the Inuvo study. So we might have a better concept of what cervical TSS looks like for bladder function then, and then you can make that decision. So more information's coming. I know it's hard to be patient. We certainly aren't. So do your best.
Thanks. I want to thank Emma and Kyle, two amazing people at an amazing center. Again, if you haven't already, check out the NorCal SCI grants. If you're newly injured, less than 2 years out, the Franklin Project and newly injured grants. And if you're lucky enough to go to Utah and go to Neiroworks, you will meet this incredible team and see this facility. It's just can't recommend it enough. And thank you both for contributing your time. I know you're both extremely busy, so much going on in your lives. So to give us 90 minutes is really generous. So thank you for that. Thanks for everyone who joined. I know a lot of people signed up who aren't on because a lot of people wanted the recording. So the recording will be made available and sent out in an email to everyone as well. So thanks everyone for joining. Have a wonderful afternoon and evening. And do your research, try it out. Good luck to you. Thanks everyone.
Thanks, Emma and Kyle.
Bye, guys.
Bye, guys.